thank you again to all the speakers. I'm now going to come back to you all again with questions that we've received based on the presentations that you've given. And perhaps, James, if I could come back to you first, please. Reflecting on your experience, do you think NHS leaders and boards are sufficiently trained, a bit like the point that Naeem's just made, are we sufficiently trained and supported to use data for decision making? What would you like to see happen, and what do you think will be the impact of AI?
Right, quite a bit in that. So I think on the training side of things, the answer is clearly no. Funnily enough, in this organisation, we've just been looking at our quality management system and how we start to build that, and that whole middle management tier. And if you go back maybe a decade or 15 years or so in the NHS, there was a huge amount of investment in the development of that middle management tier and helping people to be able to interpret data, understand capacity and demand management models and so on. And a lot of that disappeared as the money started to get tight about 10, 15 years ago. When we look at that tier of the organisation at the moment, they are a different group of people to perhaps we used to see. And what we often see in that system is an over-reliance on people asking for more BI support. It seems to be the most common response to the problem is we need more BI support. Yet, if you bring in people like Strasis or others that we've worked with, what they'll tell you is, we're awash with data, really. It's that we don't really know what we're looking for and how we're trying to resolve that problem. So I think there's something about at board level turning that into sort of that zooming out, and in particular that zooming out integrated storytelling type data. But then there's something about the capability of people at a sort of middle management level and what it is that we want out of them. I think for AI, I'm not an AI expert, but I think for me, it's back to that point of getting the basics right, first of all. And I think everybody sort of said that at one point or another through today. I still know there's quite a job to do in the organisation we're in now around triangulating data at an operational management level that's going to result in an outcome for patients that's great. But strategically, we're still looking at that in slices in some instances. So, yeah, I think definitely we need to do more training, development and support. AI isn't the answer to everything, but it's going to be, like everything else, another advancement. But if we don't get the basics right, it's not really going to help us.
Thank you, James. And Chen, I'll come to you, if I may, on this same theme. What would you like to see changed to support the greater adoption of data-led decision-making in the NHS?
I mean, I'm going to be, in danger of repeating what you've heard, but the truth is we need more human-friendly solutions. So a dashboard is not human-friendly, not for most anyway. When you want people to engage with data, stop thinking a graph, a chart, a table. I would even challenge a number. I would 100% challenge the hundreds of pages of board reports that we have in the NHS. There is no way a board is making good decisions on those reports that I've seen and I've been in those boardrooms. What we really need to start thinking is go and find out how people really make decisions, what really causes them to have a reaction, and then start to think through how are those decisions being influenced, so you build your solutions around that. I mean, people who know me will know that I am different, but when I'm good different, I challenge the norm about things that just doesn't work for people. So we seem to have sleepwalked into an era of, oh, that's just the way it is, and lose the ability to think critically about how to troubleshoot or problem solve. We're over 10 years into electronic patient records implementation, over 20 years into MPFIT, which is a national program for technology. I see the same behaviors, the same issues, the same way of working. That means we continue to have incredible waste for very little to show at the front line and for our patients. So really, my biggest hope for the NHS is that we stop accepting the norm. We think very critically, and it is true that most boards have to be brave. What James is describing to you, you don't hear it. I don't hear it from chief execs. We just have to be, and we have to stop thinking that there's going to be one new shiny toy that, you know, we're going to get on with to solve the complex problems. It isn't. I mean, healthcare is complex. So I just hope that people start challenging everything that's being put in front of them is what I would say.
Thank you, Jen. Gareth, if I move on to you now, you know, many would say, and we would agree, that the NHS is probably relatively data rich, and primary care as part of that. Do you think in your day-to-day work we could be doing more with what we have before we jump into the next new thing? What do you think needs to change to make us use better the resources that we have now?
Yeah, I absolutely think that you don't need to scratch the surface very far looking at primary care data, and you certainly don't need AI to see that there is enormous potential for intervention. And a lot of that intervention is very simple: treating cholesterol, treating blood pressure, giving people stopping smoking advice. These are all really simple things, but they get crowded out by either the firefighting of day-to-day care or the latest thing that comes along, which is shiny and new. Inclisiran is a brilliant example of a new lipid therapy which might benefit a very small number of people and might really help a small number of people, but took up a very large amount of bandwidth and of people's policy making decisions and people fighting about who was going to be responsible for paying for it. And we have to get away from that model. We have to concentrate on the easy stuff first, especially when that easy stuff is cheap. But we need to make sure that NHS resources are being directed to where the most benefit is. And at the moment, that's not happening. If you just look at something like hypertension or lipid management, primary care has minimal incentive to deliver these really important things that would have a massive impact on population health.
Thank you. Staying with you, Gareth, we've had a question from one of our delegates this afternoon who speaks as a patient voice champion. How through mechanisms such as that can we check and challenge the use of data to manage patient outcomes in all cases, not just in the more complex ones?
But I think that's about relationships, and somebody mentioned that earlier on about what patients want is a long-term narrative and a relationship where they can understand what's going on with them. And unless we invest in those relationships, then we're going to really struggle with what patients actually want and perceive as the outcome from interactions with healthcare. If all we're going to boil this down to is messages that are sent electronically to patients saying your blood pressure is not controlled, you need to take more medicines, then we are really going to be in trouble, because patients will not like that, and they won't respond very well to that. So much about patient care is about the trust that you build with a clinician and the long-term story. And I'm not sure how AI helps us with that.
Yeah. Okay, thank you. Naeem, back to you, please. We experience every day the big financial and performance challenges that the National Health Service here faces. What's your take on this? And when it comes to making the best use of data, how can data better help us to address these challenges?
So it's a good question. I think I see it as an opportunity, David. If the moment is right, it's an opportunity in terms of what we're facing, isn't it? If I talk to some of the boards, my conversation is an impossible task, right? We are kind of playing with numbers, but what's the reality in terms of our resources, how we're using our resources and how we're delivering value. So I think it's a real opportunity for boards to kind of step back and do two things. One is, okay, what is it they need to do to tick the boxes just to get past the next few months? But actually in parallel, what's the real answer? In reality, what do we need to do to get this organization, the system back to stability? And I think this goes back to a lot of the themes which came out from this conversation. You know, how do we move from perhaps lazy thinking, what I refer to as controversially lazy thinking, as benchmarking, you know, that's how do we compare ourselves to another organization? I think what it's an opportunity is to bring that critical thinking back into the conversation in terms of, you know, does 4-hour A&E matter? Is that the right thing to fix? Or is it actually a failure service where we need to kind of fix stuff outside? What does that look like? Until we get to those root causes and start using data to look at the real issues, I don't think we're going to be making much dent in the financial picture this time around. In fact, you know, next year is going to be, from the sounds of it, going to be even more difficult. So I think boards, you know, going back to my points earlier on, how do we carve out some time, some thinking time, some space to allow themselves, with all the different hundreds of things going on, to start getting a really better understanding of how they're spending the £1. I always get surprised when I ask a simple question of, you know, how do you spend your £1 across the organization? And I get so many different answers. And the other classic question I like to ask is, how many people walked through the door yesterday? And everybody can talk about elective activities or outpatients, so on, etc. But very few can tell me, oh yeah, you know, there were 10 naimes who came through the door. I think it's the basic stuff, going back to the conversation. If we understand that, then we can start picking out those few things we can make a real difference. I think one thing that James kind of demonstrated in a number of previous lives was, once you pick something which everybody can get around, you know, they will stop everything else and make that thing happen because it's the right thing to do. So I think there's a real opportunity to kind of, you know, manage the gods and angels above in terms of tick boxing, but really, you know, we should be focusing on the consumers and what value we need to the consumers. And I think it's a great opportunity, but you have to create the headspace to do it.
Yeah, and just sticking with you, Naeem, one of the questions we've had again from a delegate making reference to the medical innovations that are happening globally every day. We're able to do fantastic things now that we couldn't do before in developing new models of delivering effective healthcare. AI is there, but it's just one of those. Is the focus on AI, does it have an opportunity cost, which mean that we lose out on addressing some of the real issues that matter most to the patients?
A great question. And I think it's, you know, what we have to ask us a basic question in terms of who are we as organizations, as systems? Why are we here? We're here to improve the lives of the people we serve, right? We know what pain points are going through, what issues they have. We know, for example, there are things we want to do, but we can't do because we're limited by time, resource, staffing, and so on. I think if we stay true to those questions, if we stay true to the way, or, you know, understanding how we're adding value, then AI is just one of many tools, right? And I think boards need to build that confidence to be able to, firstly, appreciate, look, we can't do everything to everyone. You know, that's impossible. So we have to make those trade-offs and choose what we want to focus on. And I think if we do this, then, you know, we can start balancing in terms of, you know, where do we use AI, where do we not use AI, where do we need to use other technologies. And I think the important point is return on investment. We have to always think about that. I think that sometimes missing in the boards. I don't hear that often in terms of, you know, it's usually we've got X is doing it, we've got to do it, or Y is asking us to do it, we've got to do it. So I think we have to go back to who we're doing this for, who we're actually creating value for. And I think that will help in terms of answering the question. I think just to add to that also, there is a problem within healthcare services, and particularly in the NHS, where we do have new technology, it's embedded, but we fail to scale it up. And there's a huge amount of opportunity costs lost there as well. But the other thing which we forget to do is change the way we work. If AI is going to come in and make a difference, okay, well, how does it change the workflow? How does it change the operating model? How does it change the business model? How does it change the payment mechanisms? I think those are the real value add things we need to think through. But I don't think we're doing that right now. I think we need to do more of that.
Thank you, Naeem. We've got another question, and I'll come to James and then to Gareth, if I may, on the same questions. The one about how we can best incorporate patient voice into how services are informed and developed by data. James, would you like to go first, please?
Yeah, well, I mean, some of that, it comes back to a bit what we discussed before. The segmentation work we've done on population with Strauss was very much informed by patient voice. So a lot of it came from patient surveys, different analyses and data points that told us what patients wanted. And probably a bit that we haven't mentioned yet was we talked about completely realigning the way we look at the sort of the strategic view. But what that segmentation really did, I think, for the first time was I remember standing in lecture theatres with circa 50 to 100 clinicians at a time, walking them through this stuff. And it's probably the only time I can remember the whole lecture theatre of clinicians all nodding at the same time to something we were presenting to them, because it wasn't about, you know, there were 5,000 of these last year and productivity wasn't what it needed to be. It was this is the type of so for example, we had a segment of that population that was an unwell high consumer that didn't really have any contact with local health services until they either walked through the front door of the A&E unknown to us, or perhaps weren't registered with GPs from deprived backgrounds, other issues. And as we started to talk about that, you could illustrate that point, describe that persona, describe that data when it looks like when it's pulled together into that persona. And you'd get clinicians saying, yeah, that 4 or 5 people like that in my clinic every day. Right, you know, what could we do about that? But a lot of that data was brought together by Naeem's team, actually collating stuff from various groups for specific conditions, people living with conditions, and analyses about what they wanted, but also sort of surveys and patient surveys too. So there's lots of ways we can do that, I think, or it can be done. But it's got to be part of that overarching 360-degree view of that persona or that patient population, rather than just yet another strip of data that we have sitting alongside all the others. It's back to that triangulation and integration. But I think that worked very well for us. And certainly when we spoke to patients about what we were trying to do, they recognised those personas as well.
Thank you. Very good. And Gareth, anything to add?
Yeah, so I'd add that the model that James showed at the beginning is the key thing. So you start off with an analysis of what are the patient needs and the patient desires and the patient wishes. And the things that feed into that are both data and other analysis of getting information about what patients' wishes and needs are. And you need to bring those two things together to get an overall view of what's needed, what's wanted, and then work backwards from there, rather than the usual policy at the beginning. Then we'll go upstream from there.
Thank you. Okay, I'm conscious of time, and I need to draw the session to a close. There's a number more questions that have been raised by delegates, and I'll ask the Stratis team to think about when we do the summary of Q&A, which will be on the web page soon, how many more of those that we can pick up and make reference to in the write-up of the event. But before I finally close in the next few minutes, I'll just ask each of the presenters, please. It's a snappy question that demands a snappy answer. What's the one thing you would urge every leader to do when they leave this webinar in order to use data differently? And James?
Probably predictable, but what I showed on the slide earlier of start from the other end to the one we usually start at. Start with that consumer focus and try and look at it from that lens rather than what we're being asked to deliver. And I think you come up with a different answer.
And Jen?
Annoyingly, I have exactly the same answer as James. I was more thinking about the fact that, you know, when you ask people what their problems are, it's not the long wait times. It's not the poor performance. They have very, very real problems, like the fact that they can't log in. A clinician cannot log into a computer when they're doing their outpatient clinics, which means they cannot be putting in patient notes and they're still writing on pieces of paper. So you've spent 10 millions on an electronic patient records that clinicians are not using. You know, what's the point? So really focus on trying to get to the bottom of the problem you're really trying to solve.
Thank you. And Gareth?
I'd agree with James. I'd also add we need to think about distributing resource in response to what the data is showing us about the need, even if that means you have to make some unpopular decisions.
Excellent, thank you. And the last word for you, Naeem.
Thank you, David. I'll keep it really simple and practical. So request would be is for leaders to spend 1 hour of their board development next time around to talk about what they can do with data to make better decisions. Just take 1 hour out.
Excellent.
Ours is tomorrow, Naeem, so you've given me a problem now.
Okay, thank you to all 4 of you, and thank you to our delegates very much for joining the webinar. A recording and the summary Q&A will be on the webpage soon. Please don't forget to fill in the feedback survey. It takes just 2 minutes of your time to help us improve future events and understand what topics you would like to see covered. The next webinar is scheduled for the 4th of March 2025, how to make health systems work. I'll certainly be subscribing to listen to what people have to say, and I hope you will too. So thank you all very much indeed. Really appreciate all the time that the speakers have put into this fantastic session that we've had today. Don't forget to subscribe to the Strategies Thinking Differently newsletter for a great source of learning and development for us all. Thank you all very much. Bye-bye.